Menopause Society, as they push me to dive into the lipids. So as all of we know that cardiovascular disease in midlife population is underestimated, underdiagnosed, and less understood. What is the new? Actually, they give me the topic. So the traditional approach was to focus only on LDL cholesterol targets, but in modern guidelines, they had made it gender specific. They emphasize instead of 10 years risk, they put the lifetime risk, early intervention, and the goal is lower for longer. This is the menopause transition. There are changes in the lipid, as we all know, increase in total cholesterol, increase in triglyceride, decrease in HDL, and increase in LDL. So the first and the most important thing what they emphasize is start screening, not just look at the adolescent or reproductive health only or menopausal health, but start screening between the age of 18 to 39. There should be at least first lipid profile is necessary, and then repeat as if 4 to 6 yearly when required. But as we are discussing of midlife, the annual lipid profile and that too extended lipid profile we will go for. So, and currently they are focusing on non-fasting. So far we were doing all fasting lipid profile, but non-fasting is now in the guideline. This is all what we are looking at. Total cholesterol, triglyceride, LDLC, HDLC, more than, there is a mistake. So when we look at only this much, then immediately calculate from cholesterol, just deduct the HDLC, and that will give you the idea of non-HDLC. That is what we want. And the why non-HDLC? Because non-HDL cholesterol, that represents the total cholesterol content, right? So the total cholesterol content, and that should be less than 130. See, this is very, very easy when you look at the lipid profile. The second thing is include in your that apolipoprotein B. At least write down apolipoprotein B, which is a superior measurement of atherogenic particles. So even the smaller size particles, if they are more in number, the risk will be more. Then lipoprotein A, which is genetically determined 80%, and if it is high, then we can predict the premature ASCVD risk. So, and also look at in the profile only, just look at the triglyceride and HDL cholesterol ratio. If it is more than 2, that gives us the clue that this is something abnormal. She may likely to develop metabolic syndrome. Now, apart from that, in midlife, so extended lipid profile, count non-HDLC, include apolipoprotein B, lipoprotein A. If possible, then take HSCRP, that is highly specific CRP, which gives you the low-grade long-term inflammation. And today in the morning only we discussed regarding the coronary artery calcium score and also the coronary intima media thickness. Even in some cases, when you look at the mammogram, they have written that there is a breast artery calcification that gives us the clue that she may develop coronary artery disease. And in current lipid management, they have given more regarding the subclinical atherosclerosis, which is a non-obstructive plaque in the coronary, femoral or carotid artery. Once you get this non-obstructive plaque, you have to treat them according to the standard high-risk patient. As a gynecologist, what is important? So when there is history of PCO, PIH, GDM, early late menarche, FGR, early menopause, POI, as we have discussed metabolic syndrome, family history of ASCVD at earlier age in female less than 60, autoimmune disease, HIV, and these are the investigation. So these are the risk enhancers, right? Risk modifiers. So whenever such cases are there, just put at the highlight. And when sometimes what happened, if you do on calculating the things, on calculators it gives a low risk or a moderate, medium risk. But as soon as this risk modifiers we will add, it turn out to be a high risk. These are the direct high risk cases in which we directly starts the lipid. So whatever the calculators we are using in a standard Western calculators, they didn't include our South Asian ethnicity. And so whatever risk we are getting, we have to multiply. There is already we are having separate the whole session on that, one slot on that. So currently what they said, use the calculator which gives you the heartage, which gives you the lifetime risk, not simply the 10 years. So look beyond the 10 years, and that is very nicely, you can all calculate all your heartage by GBS3 calculator, which is a joint British scoring system. So now, suppose if you have look at the major risk factor, high risk feature, and risk modifier, right? Accordingly, in Indian woman, we have classified as a low risk, moderate risk, high risk, and very high risk. And accordingly, any scoring system you use, but always look at the risk enhancer, always add extended lipid, CAC, CIMT, and this. Now this is the Lipid Association of India gives us the target. When there is a low or moderate group, her LDL cholesterol should be less than 100, in high risk less than 70, in very high risk less than 55, and in extreme high risk less than 30. So when you put the patients on statins, suppose, so your target should be according to the risk like this. Don't look at only LDL, look at also then non-HDL and also the apolipoprotein B. So this is a very important slide which give you the definitive lipid targets. So now we will go to what the Lipid Association India says regarding the diet. See, India is a country with a diverse culture. There are a lot of different diets, so we cannot say them like Mediterranean or a dash, but we first always in the diet we have to ask them what you are eating actually and what you have to eat. And at the last we will say them what you have not to eat. Most of the time we start it with what you have not to eat. Instead of that, now we will start what you have to eat. So fiber content is very important, and I would like to add that they put in that methi, mung and millet. 3 M's which are very important for the heartage, methi, mung and millet. And I'm so happy that Indian guidelines are, when you search on the Google, that also immediately sparks on the Google. So fiber is very important. Now selection of oil. For oil, what they said is rotate and blend. So एक महीना अगर हमने मूंगफली का लिया, तो दूसरे महीने we have to change the oil. And the most what they said is cold press, जो कच्ची घानी का oil आता है, that we have to use. Rice bran oil reduces the cholesterol absorption, triglyceride and LDL. But the most important thing what Dietetic Association of India, what they say is grow local, eat local. So हम अगर गुजरात में है तो हमारा मूंगफली का crop है, then we will use that. Suppose someone is from the northern parts, they will use the mustard. Right? So that is very important. And in many stone company करके है, in Gujarat we have a Rani and Gulab. They are using blending of the oil to make them more nutritive, aroma and also more heat stable. So for frying we can use that, but the use of oil is 3 to 4 teaspoon. अगर फैमिली को समझाना है तो बोलो कि घर में 5 बंदे हैं, यूज कीप 25 ml सेपरेटली एंड फिनिश द दोनों टाइम का खाना उसमें से ख़त्म करो. Some are we will not be able to do. As far as in Gujarat we are eating too much oil. So even if आपको घी खाना है, जरूरी है खाओ, लेकिन include in that 5 teaspoonful. right? Then they are more emphasizing on plant-based protein, legumes and lentils, and also the millets. This is very good. Soak methi. It reduces the cholesterol absorption. Amla prevents the LDL oxidation, and use less refined carbs. Nutraceuticals, we are listening that they are using garlic, they are using berberine, they are using radius trice. These all are very good, but they are having additional support to reduce LDL cholesterol. It should be standardized and it should be monitored. Now, exercise. So this is all we know, but what lipid association say that already you are having problems with the lipids. It should be daily 1 hour, not 30 minutes. It should be 1 hour. And to our patients, we must explain that what is moderate intensity. Moderate intensity means you can speak, but you cannot sing. उतना intensity से आपको चलना है. It is not like a leisure walking for 1 hour, right? And yoga, meditation, and deep breathing, all are important. Now, one more important thing is when the patients are already on the statins, what they are already having muscle pains, muscle aches, and you are adding exercise. So, in that case, tell them to do low intensity, lesser time, but don't stop statins, right? This is very important thing. These are some asanas which will help. So, Surya Namaskar rounds, Sarvangasana, this will press the liver and help. Ardha Matsyendrasana, this will massage the liver, and the pranayam. So these are very important things. So if we see the statins, it is a first line of treatment. हमें क्या करना है? As a gynecologist, when we read the reports, when we see the risk assessment, so if they are having low risk, we have to sit quietly and we have to help them for that diet and their exercise. And if they are moderate risk or high risk, we have to send them to physician, and when then physician prescribe the statin, generally they stop by themselves. कि नहीं नहीं मुझे सब ठीक है, I don't want to take. But statins are the first line and it is a gold standard for all high risk women. There are two types of statins in which hydrophilic statins which are well tolerated. Rosuvastatin is most potent, lipophilic in which atorva is most potent, and in all high risk, it is a risk specific statins. It is used for prevention. हमने statin दिया, 1 महीना दिया, 3 महीने तक, we have to stick. Adherence to statin is very important. And then you have to, if your goals are not achieved, either you have to adjust the dose or escalate the dose, but the adherence is most important. Myalgia is the most common complaint. In that case, you can reduce the dose, or worse come to worst, you can change the molecule, or there is increased chances of increased blood sugar in certain cases. So these are all the types of statins which are the high intensity, moderate intensity, and low intensity. It is always a joint decision. Now what new things are, there are combinations in the statin with the ezetimibe. In a very high risk group or an extreme high risk group, when LDL goals are not met, ezetimibe is added, which will extra reduce cholesterol. Then similarly, PCSK9 inhibitors also are there. Fibrates are used when triglycerides are too high, and there are advanced therapy with injectables also. But the very interesting is emerging therapy is gene editing and lipid nanoparticles, which is a one-time therapy, and that is under evaluation. As far as MHT is concerned, today in the morning only we have discussed that it will not as a use so far as a primary prevention, but gradually once we have data, soon we will come with that. In hypertriglyceridemic patient, transdermal estrogen and progesterone, which is natural micronized or dihydrogesterone we use. So the most important things are the checkpoints. We have four possible things to get lipids done. One is preconception, second is postpartum, 1.5 months, third is perimenopause, and fourth is menopause. Statins are safe and effective. Maintain them as a cornerstone. Think beyond LDL, right? So now from onwards, tomorrow onwards, we will see extended lipid profile HSCRP, CAC, CIMT whenever there is indicated, and identify moderate and high risk women and tell them to meet physician, and appropriate intervention is must, and provide diet and exercise prescription first to every woman. So there are incidences in which you give the diet prescription or exercise prescription, and after 3 months the lipid may comes normal. So these are the take home messages, and these are the reference guidelines, and every one of you calculate your heart age from this calculator. Thank you very much.